Welcome, everyone. My name's Camara van Breemen, and I'm one of the co-hosts for the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Today, I'm so excited to introduce Professor Gayatri Palat. She is the Pain and Palliative Care Professor at MNJ Institute of Oncology in Hyderabad. She's a consultant for Two Worlds Cancer Collaboration. She also has many other positions, including board member at the ICPCN, and is a founding member of Pain Relief and Palliative Care Society, which is also in Hyderabad. Welcome, Dr. Gayatri. It's so lovely to have you here.
Thank you, Camara.
And as you know, this podcast really does explore palliative care from around the world, and we have interest both in adult palliative care and pediatric palliative care. And the work that is being done, particularly in your country, I think is extremely impressive. It would be great to first start with what education do you have and what brought you to this incredible work?
Thank you, Camara. So, to begin with, I'm a medical doctor and my core training is in the field of anesthesia. And for some reason in India, a lot of original palliative care doctors, they all moved from anesthesia to palliative care because it's still a very new subject in India, new specialty. So, a lot of us who are otherwise doing pain interventions, pain treatment for patients with chronic pain conditions, especially like people like me, I realized while I was doing a lot of this nerve blocks, a lot of these chronic pain conditions, they need much more than just doing some nerve block. They have so many dimensions of suffering. And that made us realize, for most of us, that you need much more than doing nerve blocks. And that made me think beyond doing nerve blocks. And here I am, I'm doing palliative care because I realized at some point of time, if you want to do help those patients, you need to look at all the dimensions of suffering, not just the physical but social, emotional, spiritual, and including financial suffering which they undergo.
It's interesting. I hear you in anesthesia, you have a tool, a very practical tool to be able to stop pain, blocks, medications. So you have this wonderful tool chest to be able to help. And I'm sure you saw those things. And yet the other piece is the suffering, the other suffering that goes beyond the pain. And I think also I hear you wanted to help in those ways. Also, I think it speaks to what's happening with the family. You must have also been in those circumstances early in your career when you're watching how are they managing with their loved one. Can you say anything about the suffering of the broader family?
Absolutely, Kamara. You brought out a very important point. People with chronic pain, when they come to any health system asking for relief, it's actually a cry for help. Pain is just a manifestation of a huge element of suffering, what we see as pain. But actually, if you look at it, this a huge element of suffering, not just for the patient, also for the family. The family, including children, all of them suffer in the process. And we just, as a clinician, when we see a patient, we see someone in pain, and we try to address just the pain, the physical element of it. Often we fail because we don't realize what's the underneath the what we see on the tip. So when you talk about chronic pain, or it's all about suffering, and you have to address those suffering.
And to dig down into that iceberg, what are some of the techniques you use? What's brought you to being able to not only work with the patient, but support so many people on your team to work with patients such as these?
Yeah, so initially I was not even aware. I just realized that I'm not doing enough because they keep coming back to us in pain, more disability, pain. It's a kind of vicious cycle. It goes on and on. And somewhere I knew that something was missing. And fortunately, I had my teachers and mentors who also felt the same way. And they started exploring. And I just followed them. And I actually underwent some more training and some more observation in other places as to how they manage such chronic pain conditions, and that's how I realized like what they undergo and how to help them with interventions just beyond medications and nerve blocks. So I really underwent a lot of training as to address to those issues. It's not that today I'm an expert. At least I know now to explore those problems and find some answer to what they're experiencing.
And there, I think here in the West, there is a misconception that palliative care is really that end piece, the end of life circumstances and things like that. And yet, you've built a program. You're talking about chronic pain. You're talking about some of those patients that you see earlier on in their cancer journey potentially. What is palliative care to you, and why did you build some of the programs that you built? How does that align with your philosophy around what people need when they have a serious illness?
Even in our country, we brought this concept of palliative care, so called, as a specialty from the West. So we imported this concept of palliative care as terminal care, people who are dying. That's the understanding among most of us. But if you look at our culture, if you go back, trace back to our tradition, the caring and supporting people who are dying, it is very much so, it was a so much integral part of our caring, taking care of even dying people. It was there, somewhere we lost it with the modernization and the outlook. Thinking as being modern means you have to use more of technology, and the process we became more impersonal. Same like how it is happening in other part of the world. We are also just following the same trend. Somewhere we lost track of caring. I often think, like I heard from my mentors, when a baby is born, we celebrate, and there's so much of anticipation even before birth, and at the time of birth the entire community come together, and after the birth there's so much of joy, celebration. And when you talk about leaving this world, for it's for me and you, all of us, we dread that process. And one of the reasons what we are scared of is dying in isolation, very lonely, dying in isolation and dying in suffering. And I think this specialty, if you consider as a medical specialty, it is, I think it's beyond that. But this as a specialty, it deals with people who are leaving the world and help them living well, even though it's time for them to leave the world. I think that's a concept which I understood as palliative care.
Yeah, it's interesting when a baby comes, nobody begrudges the care that the baby needs. The baby's completely dependent. And we all, feel quite special when we get to help the baby and care for the baby. And I find too, if we could shift our culture, as you said, maybe back to some of how we used to be, it's a privilege and an honor to care for someone who is becoming more dependent. That
Mm.
care that you do is got lots of richness and intimacy and special time and mystery that I think we have lost. I was recently there visiting you in Hyderabad, and we walked through the hospice that you so I would say lovingly built, but also with so much expertise because you had to fund it and staff it and create quite an environment for it. Can you tell me a little story or two about the hospice and what's happening there?
Every person who walks into hospice seeking care, there's a story, there's a life story. All of those people who are seeking care in our hospice, when they come with a story, they come with family and the life they lived. And very poignant, some point of time, it is really, we learn so much from them actually. It's not just one patient, every one of them, they teach us in the process. They live the life full, and then they reach this part of the journey. Especially, as you know, like when we are dealing with children, it remains special for all of us for various reasons, but especially when we see a child dying, we often tend to go more deeper into what happened to their life. There are a lot of stories around that which we remember for forever. There's so many stories, yeah, but each story is unique. We learn from them.
And why did you think that you needed to build the hospice and create another arm to care? I mean, I know you do consultations at MNJ and you have beds and care for people at the cancer hospital and also in the pediatric hospital. Why did you think this special care was needed, and what was your vision for that?
One is from patient's point of view, the second as a carer from professional point of view. The two reasons why we felt that we need to have this hospice. If you look at from patient's point of view, I work in a public hospital. We cater to patients who are from very poor socioeconomic conditions. So when we do home visits and go to their homes and see them in the condition which they live, we realize that they live where the entire family is living, and this one person who's having advanced disease is in that small house shared by the family and children. And sometimes caring for such patients in such small basic facility becomes very challenging. And they have to eat food there, they're sleeping there, that their children playing there, studying there, everything happening in that small, maybe one bedroom facility. And this patient is there in the middle of all that with severe pain or a wound or a feeding issues and things like that. And sometimes they find it so difficult to care for such people in their homes. If you ask me, most patients, when you give them this choice, they want to be in their homes, surrounded by their loved ones. But sometimes they can't handle such patients in the home. And that's the reason we felt that if we have a facility where they continue to feel like as if they're still in the home with their loved ones, but in a much bigger supported environment, maybe they'll be helped better. We found that many patients end of their journey, or even when they are too sick, they opted for this facility. So that's how we decided to have this hospice facility. And from professional point of view, there's a limitation as to how much we can do in the home. And of course, in the hospital, there are a lot of other limitations. The kind of personalized care, a lot of nursing care which we can do in the hospice, we can't do in the hospital. Professional point of view, also, we felt that we need to have this hospice where can we can give absolute care to the patient, and the family can just stay by the side of the patient, relax, and they can get the rest they want, and we'll take care of the patient.
I think my experience, and I know you have had similar, is when you get them into hospice and able to do really good palliative care nursing and have the right symptom management plan and everything, they often live longer than we expect. That time becomes different somehow because when you're not in pain, when you feel like all your needs are met, when the mom can be a mom to the child instead of the nurse all the time, there seems to be this amazing energy spared to just keep living.
The only consistent thing which I found when they're in hospice is healing happens so much better. Healing, when I say it's not just about healing the wound, overall well-being and the healing, it both for the patient and the family. So we try to provide that environment where they can heal better with all the suffering.
Yeah. I love that concept of healing even while dying. People think it's a paradox, and it absolutely isn't. We met quite a few years ago. We met through friends, shared friends, and work with Two World Cancer Collaboration. And I know from Two Worlds Cancer Collaboration, our gratitude and our partnership with you in Hyderabad has been enormous. Tell us a little bit about your work and the collaboration that has happened and how you've been able to really grow palliative care across the state of Telangana.
So we're looking at two aspects. One, as to my collaboration with Tools Cancer Collaboration, and how we both coming together, me and Tools Cancer Collaboration together, trying to expand the scope of palliative care across Telangana. So my collaboration with Tools goes back to way back to 2006 when I first moved to Hyderabad, hoping to start a small palliative care center in a public cancer hospital. I thought I'll come here, set up a program, and go back. And Toowold, at that point of time, I remember Dr. Stuart Brown, he approached me and said, can you help us to set up this small program in a facility where there was nothing happening? Those were the days there was absolutely no palliative care happening in this region. And that's how we all began. And we began by bringing in small seed grant to support the staff, my position here, and support the as a facility, supporting the hospital. They gave us the infrastructure and they said, okay, you do whatever you can to help our patients. And that's how we began that small seed grant, which facilitated to set up the program. And today, that hospital is one of the nodal center in the country. Patient care, advocacy, research, training. We trained so many people and we have a postgraduate residency program happening in palliative care. So we grew from that small seed grant today as one of the nodal center. And as we showed that this can work in a government facility, and also while parallelly we were working with this NGO, where I'm the founding member, like you mentioned in the introduction, the Pain Relief and Palliative Care Society. Through this NGO, we expanded together the scope of palliative care in the community. During this entire journey, the foundation towards cancer collaboration was supporting my position here. And because of my presence here, we could help the Pain Relief and Palliative Care Society to expand the scope of palliative care in the community by means of home care and hospice. When we did these two projects, the government took notice of it and they said, why can't we do it in other districts? And that's how we embarked on this very ambitious project of setting up of district-based palliative care program in all the districts of Telangana. We started this project in 2017, and today in 2025, I can say that we have established very successfully 33 centers, decentralized, not just in Hyderabad, spread across the state in 33 districts. I'm not saying it's a perfect program, but at least there's some presence of palliative care happening in all those 33 districts. So today, if I have a patient in MNJ Cancer Hospital who goes after he has an advanced cancer, no more curative treatment possible, and he needs to go back to his village in a very far away, remote tribal district, he can go back confidently. We refer them back to the palliative care center closest to his home, where he'll continue to get support, special pain medicines like oral morphine. He need not come back to Hyderabad just to get that simple tablet of oral morphine. He'll get it nearer to his home. And that's how this collaboration beautifully work. The government, towards cancer collaboration, and this local NGO called Pain Relief and Palliative Care Society.
You describe such a beautiful network, so that, or probably even a net, I would say, because those patients are caught. They're caught wherever they go home to. They want to be home, and yet it can be hard to go home unless you have that network of people that know what to do as the pain increases, as you get sicker. Support for the family, just amazing. I could talk with you forever and ever, and I am so glad for our connection and our work together. As you look ahead, Gayatri, maybe the next 5 years, I know you're always moving and seeing vision. You're such a visionary. Is there one or two things that you're really hoping for in your next projects, in what you're going to do next?
Yeah, so again, couple of things which comes to my mind when you ask this question. One is last couple of years there was a kind of cascade, like so much of escalation of what we were doing. It's always like that. I think we have so many people who need palliative care. So once you start a program, it just there's no going back. Like it just explodes because there's so many people who are seeking help. So we grew exponentially last few years, especially in terms of pediatric palliative care. So we started with general pediatrics, then expanded to neonatal, and today now we have perinatal palliative care. So it's a huge number we are talking about. So somewhere I'm worried about the quality getting lost. I don't want to get the quality getting compromised. So I want to consolidate what we have. That should be my focus. I feel that consolidating the program which we have both in the hospital and in the community, and if I have any means, even to ensuring quality in those district programs, ensuring quality and mentoring to all the programs which are done. The second thing I would really wish is maybe because of my own personal experience, this is my own personal thing, that I want to explore more around other non cancer conditions, especially people who are with cardiac conditions. If only I have some ways to explore more around that and see how what's happening to people who are with cardiac conditions in their stages and how what kind of suffering they undergo. I want to explore that further and see is there any way we can support them.
Thank you so much. There is a lot of work ahead, and I think what I see you do so clearly is you do keep a presence, even though there's so many places now that you're embedded in. You keep a presence, you follow up, you check in, and then the other place that I see you just expand this work so much is providing leadership and really finding people that can be leaders and you mentor them. Is there any tips or tricks that you have in how you identify that person that can help not only help the program grow, but also maintain that quality? What do you see in people that you encounter that really can provide that leadership?
I think for leadership, of course, there are a lot of leadership qualities which we all talk about, but I think two important core quality which will help to become a good leader is that your own competency and experience. So whatever we say, when it comes from experience, it carries much more strength and credibility. But you have to be good in your subject as well as experience both. So you have to really work with patients. You just can't sit in a classroom and talk about it. You have to do it and show that. We call it as modeling the way. So having this your own competency, you should be well trained and you should know what you're talking about and show it yourself. That's the only way you can be a good leader.
I just love that, Dr. Gayatri Palat. You are modeling the way. And I thank you so much for your work, for the difference you make in this world every single day, and for our friendship. So thank you so much for being here today.
Thank you so much. It was my privilege to have spent time with you today discussing about my life and my work and our friendship. Thank you.
So thanks for listening to this episode of Sunflower Palliative Care Podcast. These podcasts grew from the seeds of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration focusing on children's palliative care. We hope to build a world where no child suffers from serious health-related sufferings. To learn more or donate, please visit twoworldscancer.ca. Thanks very much.